Good morning,
Good morning, Dr.
everybody,
Kinney.
and thank you, Pakistan Live, for this opportunity. I'll be talking on best strategy for left main bifurcation in 2023. I'm Dr. Kinney, director of the Cath Lab at Mount Sinai in New York. So, left main bifurcation stenosis is about 5 to 7% of the cases that we see. More than 80% of the stenosis involves the left main bifurcation. The largest coronary bifurcation, because the reference diameter can go anywhere above 4.5 plus or minus 1 millimeter. The left main length also varies from 10 millimeter plus or minus 5, and distal bifurcation angle, which many people consider is important, which is considered 70 or more. Continuous plaque from left main into proximal LAD about 90%, then into circumflex 60%, and from left main to both, which is Medina 111, is about 60% or so. So evolution of left main bifurcation technique over the years. If you see here in 2013, we started with the DK Crush 3, which showed DK Crush was better than Culotte in two-stent technique. Then Culotte was better than the TAP technique in BBK2 in 2016. DK Crush better than provisional stenting in complex lesion in the DK Crush 5, which I'll be discussing a little bit later. And then provisional, which is equal to two-stent technique, which was shown in EBC main. So DK Crush mostly done in China, the others done in Europe. What really has not been tested was DK Crush technique with the mini crush technique yet to date. So most of the people discuss the DK Crush 5 trial, which was a combination of DK Crush technique to provisional stenting in left main bifurcation. What was important, if you see here, about 482 patients were part of this trial, and 40% was IVUS guided. They used what is called as a definition criteria of a definition trial, where mostly complex lesion. That means if you had left main distal two vessels, the LAD as well as circumflex had lesion, there was calcification, the length as well as the angle, all of this were considered. If more than two of the criteria was there, was complex, otherwise was called simple. And what they did was, compared to provisional with the DK Crush, if it was complex lesion, definitely two-stent technique using DK Crush did better. Now, very important, what we learned from this trial was bailout stenting. So 47% of the patients in provisional stenting, that if you did single stent, 47% of the patient required a second stent because of suboptimal result in main vessel stenting. If a complex lesion underwent a simple single stent technique, 38% of the patient in simple as well as 64% of the patient who required second stenting in a complex lesion if they went to provisional stenting. What also they saw is that if you did bailout stenting in true bifurcation lesion, then the outcome was poor. So essentially saying that if you have complex lesion, try to do two-stent technique. Otherwise, you will have poor outcomes. So at 1 year, what did we see? That the target lesion failure was higher in provisional stenting, mostly related to MI or stent thrombosis. And at 3 year, not only was there a difference in MI as well as stent thrombosis, even TLR was higher if there was provisional stenting. So that is the same point that we learned. What was the EBC main? In EBC main, they compared two-stent technique, which most of it, 53% was Culotte and 5% was DK Crush. And other they did was provisional stenting. In that, if they needed something, they did TAP technique. So 53 and 32%. No difference between any of these techniques. So there's a difference between DK Crush and EBC main. Essentially, DK Crush used complex lesions compared to EBC main. That may be the reason we never saw technique. Definition criteria I discussed a little earlier, and very important is the same thing. Major criteria, minor criteria for left main, non-left main. Essentially, Medina 111, stenosis greater than 70%, length more than 10 millimeter, or minor criteria are very small. So this, what did, if you see here in the definition, this was non-left main, to be clear. DK crush was used in 78% and Culotte in 18%. And most of the difference you saw that planned stent technique was better, two-stent technique compared to provisional, and differences was seen at 1 year. At 5 years, 3 years, there was no difference in outcome. IVUS was used in about 27% of these patients here. So again, the same, that if you have complex lesion, try to do two-stent technique. And if it's a simple lesion based on this definition criteria, provisional stenting is okay in this patient. Then comes, we always discuss which is a better technique, and everybody do talk that DK crush for most of this technique probably is better. And if you see here in this paper, the patients who experienced cardiac death in unprotected left main PCI, they were grouped into tertiles according to the operator experience. So very, very important. Who were these people? So operators who were high volume, who considered more than 24 cases per year. These are the people who operators did a better job. If the low volume operator actually had a poor outcome. So very important, who should be doing this kind of complex procedures in this day and era. Then, is imaging very important? So there is multiple trials as well as data showing that intravascular ultrasound in 2014, about 50% of the cases are done using ultrasound. And if you used ultrasound, imaging versus no imaging, definitely the outcome is much better at follow-up in these patients. So having all this data out there, intravascular ultrasound has become the part of the current guidelines. So IVUS, which has been 2A for procedural guidance of complex coronary stenting. So left main falls into complex coronary stenting here in the left main. You can also use OCT if not for IVUS in some of these cases, except for ostial left main disease. So pre-lesion assessment, which will be plaque morphology, stent sizing, and landing, as well as post. Most important in the post is optimization. So IVUS use has been shown here in majority of these trials. Both there is 2A even in European guidelines. So this is a recent paper that just came out, which is saying that if patients with left main with a syntax of less than 22 is appropriate to undergo PCI, left main with syntax between 23 and 32 is 2A. But again, in the guidelines, DK crush has been part of it with 2B for this kind of cases here. So the same thing, the central figure, which is saying that baseline complexity assessment based on angiography or IVUS. Same, if the patient has complex lesion, consider two-stent technique. If there is no complex lesion, you can do provisional stenting, and then you consider crossover. And when do you consider crossover? That your side branch has a TIMI flow less than 3, there's a side branch dissection, or you have side branch stenosis greater than 90%, which can be confirmed by IVUS, and in rare situation, they are saying you can do FFR or IFR. There is no study to prove that FFR, IFR of the side branch, which actually was DK6, did not show that there was any difference, but somehow it has made it to the guidelines that you can do FFR, but there is no study to prove that, and intravascular imaging is a must. So Mount Sinai, we do a lot of live cases. We did about 48 live cases in 2022, 20 bifurcations. Of that, about 10 were left main bifurcation, because majority of the people would like to see how bifurcations are being done. And this is the case of left main, where we did intravascular imaging, showed the disease in the distal left main, ostial circumflex distal left main. Also, you can see there is a nodular calcium. We did rotational atherectomy followed by two-stent technique, and this is how the final result of it you see here with good optimization even on the IVUS. So this is the future of bifurcation in 2023, which we are working on using AI, where you, after doing angiogram, there'll be automatic QCA detection, followed by the apps that we have created, which will tell you which particular technique is better, and a step-by-step guide for treatment of this complex PCI that we are talking about. So in summary, ladies and gentlemen, complex distal left main bifurcation planned two-stent technique is superior to provisional stenting. High volume and experienced operator for left main PCI has better short and long-term prognosis, and pre and post PCI intravascular imaging assessment is recommended for complex coronary stenting. AI-powered cath lab is closer than ever. Combining our experience in complex bifurcation lesion treatment, we will create an AI algorithm to automatically analyze bifurcation lesion and use our educational work to recommend technical devices. So thank you for your attention. We have multiple apps, Bifurcate, for which is that 3D animation that you can see here. All these are free to be downloaded. You can go to cardiologyapps.com and see several other apps that we have made for all the interventionalists. Thank you.
Thank you. So what she told for the younger cardiologists, this Bifurcate, it's a very good app, you know. My question, obviously we have discussed, she has discussed all the bifurcation strategies. My question to Dr. Chen, what about the Chinese experience for the provisional stenting using the jailed side branch kissing balloon technique? The jailed side branch technique for provisional stenting. What's your experience in China?
Yeah, almost from 5 years ago, jailed balloon became...
Can you speak closer to the mic?
So
yeah, thank you.
Almost 5 years ago, jailed balloon became popular in some Chinese centers, but not too much. But in China, you know, this year we just published the first guideline for left main bifurcation stenting. This is the first guideline from China. We summarize all the international data and to provide more interesting cases. But personally, from my personal opinion, I don't like jailed balloon because there are many problems regarding the jailed balloon. So I still prefer jailed wire. Thank you.
Thank you. So now, you know, you have been a wonderful audience. Now I'm going to hand over to this podium to the second moderator for the session, and that's none other than Dr. Bashir Reef, who is also the course director for this Pakistan Live 2023. So over to Dr. Bashir Reef to take you to the second half of this first session. Thank you very much.